another video from HSTV, and in today's video, as you can see by the video title, this is part 3, the final part of the ECG series, where we will be going over some common arrhythmias and examinable content that's likely to come up. So if you haven't already, do go and watch parts 1 and 2, as this is really a continuation of that. And yeah, if you're new to the channel and you don't know who I am, first of all, why are you still new? But secondly, my name is Heen Shamaz. I'm a 5th year medical student here at the University of Edinburgh. And without further ado, let's jump into part 3. Alright, so part 3 then. This is all about your common rhythms, okay? And there's not really an easy way, okay? So this will become pattern recognition over time. The best advice I can give is just to look at ECGs every day. Honestly, when you're on placement, you can see them online as well. There's lots of resources and websites. Have a look at as many ECGs as you can, and you'll start to recognize patterns as you go through, and you won't actually have to, work it out as much like we've been doing. But yeah, let's first of all talk about tachycardias. So, tachycardia is a fast heart rate. Specifically, any heart rate that's sort of above 90 to 100 beats per minute, we'd consider a tachycardia. But there's lots of different types of tachycardias. So specifically, if we have a look at this ECG here, we can go through our little algorithm. Make sure you have watched part 1 and 2 before you come, because this algorithm we talked through. Now, the first thing is the rate. So what you can actually do, remember, so rate is going to be, if we actually go back here, this is useful for you to know. So remember, you can do a heart rate of 300 divided by the number of large squares between R waves. So if we keep that in mind and come here, because this is a regular rhythm, we can say that there's perhaps around about 2 boxes, so 2 big boxes, and if we do 300 divided by 2, that would be 150 BPM, which is pretty accurate. The rhythm is regular, as we've already said. Next up, looking at the P wave, so we can actually see P waves there. They might not be very visible to you, but you can see P wave, P wave, P wave. P waves are a bit more visible. Let's have a look. So you can see the little P waves in AVL as well. You can see it there in AVF. But yeah, we've got nice P waves throughout. So this is showing that we are in sinus rhythm. Because remember, why are we in sinus rhythm? Because when the action potential produces this positive charge in the atria, we are getting a positive deflection, and that is showing us a P wave. So that's sinus rhythm confirmed. Width of the QRS complex. So the QRS complex is hardly one little box, so one small box. That's showing us that it's definitely less than 3 small squares, and it's normal. The Q wave. Well, the Q wave, as you can see, I mentioned this in the other parts, but it really shouldn't be visible. And if it is, it should be very small. And you can see here that our Q waves are pretty much non-existent. So we know that that conduction through the septum is quite nice, and it's fine. So it's not deep, not indicative of any ischemia, so it's all good. ST segment, well, you can have a look at your ST segment here. So your ST segment, you can see right here. So your S wave was right here, coming up to the T wave. Well, that is pretty much at baseline. Baseline meaning at the line of the, at the isometric line of where your P wave is. And you can see that that's not raised. That sort of comes up nicely into your T wave. So we are at baseline, which is fine. And your T waves are nice and upright. Therefore, because there's no other abnormality here on this ECG, we've got good R wave progression as well. You can see that the R wave gets taller, S wave gets smaller, V1 to V6. There's no kind of elevations or irregularities, and therefore we can call this a normal sinus tachycardia. I know we're not going into much of the pathophysiology, but really this would be something that you'd see if you did 10 star jumps right now. You'd have a bit of sinus tachycardia. Okay, Now, there's other types of tachycardia as well to be aware of, and there's two types. You get narrow complex and you get broad complex. So to first of all talk about narrow complex tachycardia, you have three main types to be aware of, and the first one is very common. You see this all the time in exams, you see this on placement as well, and that is atrial fibrillation. And you can see in atrial fibrillation that it's irregular, okay? And it's irregular in that you can see that if you counted the number of large squares between peaking QRS complexes, that's irregular. I mean, that's 2.5 there, hardly 2 there, 1.5 there, maybe 1 there, 1.5 there. It's all irregular. It doesn't take a genius to see that. But you need to understand what's actually happening. So atrial fibrillation is really when the conduction in the atria is not coordinated properly. So you're actually getting these sort of impulses, these action potentials being produced at sort of the wrong time. It's uncontrolled. And the reason it's narrow complex, and you can see that your actual QRS complexes look normal, is because it's affecting your P waves. And when you've got something affecting your P waves, that's indicative of atrial problems, right? So atrial fibrillation being a very common one, also atrial flutter, and also your supraventricular tachycardias, which are again affecting your atria. These are the ones where you want to do some vasovagal maneuvers, or you might need to give some adenosine to correct it. But yeah, that is what they look like. This is what to look out for in lead 2, in your lead that they run through for you. And main things to be aware of, well, QRS duration is going to be less than your 3 small squares. This is not really affecting the ventricles. Your QRS complex are pretty much normal. However, it's this uncontrolled feeling. It's not in sync. It's not regular. It's irregular, in atrial fibrillation, as you can see. And most importantly, it's affecting the atria. So these are atrial tachycardias. Now, I hope that you would have guessed that a broad complex tachycardia is then looking at the ventricles. And as you can see, these look very, there is something wrong, you would notice this. So your QRS duration is over 0.12 seconds, it's over your 3 small squares, and these are ventricular. So here we have a ventricular tachycardia. That is what it looks like, and you can see here that actually, unlike the atrial tachycardias where the ventricles were okay, they were quite normal, these ventricular tachycardias and ventricular fibrillation, they're a lot more serious. You're not having those P waves, you're not having good conduction throughout the heart at all. So these are a bit more life-threatening, and the ones where, ALS and, life support and that sort of thing comes in. Okay. Let's talk a bit about heart block then. So we've spoken a bit about these fast rhythms, but your heart block, now you have different types of heart block, mainly 3 types. So first degree heart block is also known as an atrioventricular nodal block. And the reason for that is because what happens is your PR interval. Now going back, remember all the way in part 1 when we labelled the waveform, the PR interval is from the start of your P wave to your R wave. So you can see that this P wave happens almost after your T wave, and then you have this really big delay before we get to our QRS complex. And the reason for that is that at the atrioventricular node, where that charge, remember, was being held for a few milliseconds, it's being delayed there for a bit longer. So that PR interval is longer than the usual 0.2 seconds. However, this is constant. So you can see, look at the P wave here, look at the P wave here, look at the P wave here, and you can see that prolongation at the AV node is about the same throughout. So this one is not very serious, so it can actually happen to people like athletes, and there's not really a big management for it. So this one is not as serious, it's irregular, it's a prolongation of the PR interval, it's called first degree heart block, but some people might also refer to it as AV nodal block as well, because that charge is just being held there for a bit too long. Okay, moving on to a few more heart blocks then. So second degree heart block is split into two types. You get Mobitz type 1 and you get Mobitz type 2. So we will go through both of them. Mobitz type 1, the thing to know about this is it's irregular. And what happens is that the PR interval will continue to lengthen until a QRS becomes missing. So if you have a look at your PR interval here, it becomes, if we're looking at this little region here, becomes slightly longer here, and then as you can see, we miss one. Then again, it prolongs, and assuming we would probably miss a QRS complex there. So it will continue to prolong, as you can see here, 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 and then we just miss one altogether. So despite having a P wave come in, we just miss a QRS complex there. This is an irregular rhythm. You can see that because if you counted the squares between your R waves, you can see because we missed the QRS complex in there, it wouldn't be a regular rhythm. And but the main thing to note here is that you see this pattern of the PR interval lengthening until you get a QRS missing. Mobitz type 2, however, is a bit more dangerous because it can deteriorate to the third type of heart block, which is complete heart block, and we'll talk more about that as well. I've seen this in exams. It can actually be quite confusing to differentiate a Mobitz type 2 to a complete heart block, but the thing to know here is that your sinus impulses are at irregular intervals. So unlike Mobitz type 1, where we sort of had a pattern of a PR interval prolongation and then a missing of a QRS complex, here we actually have P waves in sort of random places. So we've got P wave there, P wave there, P wave there, P wave there, no QRS, P wave there, P wave there, P wave there, P wave there, no QRS complex. So here actually we couldn't actually predict when we would miss a QRS, if that makes sense. So you would get your P waves in all their places, but just the QRS becomes missing randomly, and you just don't know when it's going to be. So again, it is an irregular rhythm, and it can deteriorate to complete heart block. Complete heart block then, well now, the atria and ventricular have had a bit of a fight and they are beating independently of one another. That communication, that vital communication, is no longer there. So you're actually having random impulses, and that's not good at all. Again, I found this picture quite useful because it labelled to us the R waves. I mean, look at them. They're right here. And the P waves, again, random. Not good and quite difficult to pick up on as well, I would say. The easiest way I can say is that R wave is still sort of narrow in these rhythms, and your P wave again is upward deflecting, but again it's random. So just be aware that if your P waves and R waves are all over the place, then it's probably a complete heart block, and they can be caused by inferior MIs. Okay. Let's speak on ST segment abnormalities. So remember, first of all, from part 2, when we tried to apply our knowledge from ECG waveform into actually what the different parts and these different leads on an ECG are correlating to. Remember that your right coronary artery is supplying the inferior region of the heart, which is indicated by leads 2, 3, and AVF. Your lateral regions are shown through AVL, lead 1, V5, and V6, innervated, well not innervated, but supplied by your left circumflex artery. And your anterior septal regions running from V1 all the way to V4, supplied by the left anterior descending artery. just remember these regions because, you know, if you want to be a cardiologist and you have somebody who comes in with ST segment abnormalities in, I don't know, maybe AVL and V6, then you are thinking of doing a PCI, a percutaneous kind of coronary intervention, some sort of stent put into the left circumflex artery, because it could be showing an MI there. So this is really where you want to be applying your knowledge. Looking at this ECG, we can actually see ST elevation in leads V2 to V4. Have a look at that. That is raised above from baseline. That's not how it should be looking, and that's running from V2, V3 and V4. And actually it's quite clear to say that the left anterior descending artery is affected. You might see a bit of elevation in some of the other leads, or you might see a T-wave inversion some places, but for the most part that ST elevation is clearly shown in V2 to V4, and this is telling us that we have anterior STEMI and your left anterior descending artery has been affected. An inferior STEMI, on the other hand, would look like leads 2, 3 and AVF being affected. So the ST elevation you can see is here. You can see it very clearly in lead 3 and leads AVF as well. You know, looking at the other leads, you know, lead 1, it doesn't seem to be very affected. In fact, it almost, I mean, yeah, it's not very affected. I was going to say maybe slight depression there, but for the most part it actually looks normal. Lead 2 again, you can see that elevation, and again V2 to V4 again looking quite normal, so it's quite clear to say that that elevation leads to 3 AVF. This is an inferior STEMI, inferior part of the heart has been affected, and the right coronary artery is responsible. Now, a non-STEMI, on the other hand, can present as an ST segment depression. So remember, a STEMI is obviously showing an elevation. That's the one we hear about a lot. But actually, a depression can also show ischemia and indicate an MI to us. So for this, you know, still looking at the anterior region, we're looking at V1 to V4, and you can actually see that you've got this inversion, right? So we're not expecting an inversion here. T-wave inversion, T-wave flattening is a sign of ischemia as well. So do be aware of that. You can see these like troughs almost, right? And if you have a look at you know, even lead 2, you can see that T-wave inversion and flattening has taken place here. Now these changes might look quite subtle to you, but you know, when you look closely you'll see that it's very different to your normal waveform. Again, look at ABL, look at that T-wave inversion. But because we've got it across V2 to V4, we're going to say that this is an anterior non-STEMI. Again, management for this would be a bit different to a STEMI, but again, looking towards a PCI type management, if not conservative. Okay, let's speak a bit about bundle branch block. You get 2 types. You get right bundle branch block and you get left bundle branch block. And these are always, you know, looking at like the bundle of His and those Purkinje fibers, some sort of an issue down there in the ventricles, and the conduction of the ventricles is where this would be showing. Obviously, if it's a ventricular problem, a ventricular conduction issue, the QRS complex is going to be affected. Now, I must admit, this ECG down here, I couldn't find very good pictures of a right bundle branch block. But what you want to be looking for is an M shape in V1 and a W shape in V6. Now, what that means is literally that little small W that you can see there, and the M you can see sort of up there, right? And you can kind of see it here, it kind of goes like an M there, and then the W shape in V6 you can see slightly there. Again, this diagram is not great, but I've tried to project it a bit and show you that if you see an M shape in V1 and a V6 W shape, that is indicative of a right bundle branch block. The way I remember this is marrow. So marrow is the kind of mnemonic, or the kind of abbreviation that I help myself to remember for right bundle branch block. Marrow, because it's got R's in it, showing it's right bundle branch block, but because M comes first and it's V1, marrow, W comes last, so it's V6. Okay. Again, you can see here in this diagram that this is more of an explanation of why we're getting these shapes in the right bundle branch block. So this part of the wave here, you can see it's fast depolarization, and then you get this slow depolarization, because as it comes through the septum, you're getting the depolarization in the left ventricle, but then in the right ventricle, it's slower because this part of the bundle of His has been affected. So that's where it's coming from. Left bundle branch block, on the other hand, is the other way around. So kind of opposites of each other, but you get the W shape in V1 and you get the M shape in V6. So a little bit clearer maybe this time. Look at that. You get this sort of M shape there, and you get your W shape there. The mnemonic I use for this is William, so W coming first for V1, and then L for the left bundle branch, and then M ending on for V6. So William is what I use for left bundle branch block, and marrow for right bundle branch. Now, there are a few other ECGs that you should be aware of. One of them is Wolff-Parkinson's-White syndrome. So Wolff-Parkinson's-White is a PR interval issue. And let's have a look here. So on this ECG here, you can have a look at the P wave here. If you look at that little PR interval, that little PR interval right in here, you can see it very quickly jumps to the Q wave into the QRS complex, and you don't actually get the conduction being, the charge being held at the AV node. And this is because you're getting this atrioventricular conduction through an accessory pathway. So, the heart has sort of had some sort of a hit to it, and because of that, it's formed this conduction pattern that almost bypasses the AV node. And because of that, you're not getting the charge being held at the AV node like it should be in a normal ECG. Now, the problem is that here you're getting a risk of ventricular fibrillation if your patient develops AF, or you could have this rapid accessory conduction happening. So although at the moment this doesn't look too bad, and at the moment this patient might be fine, the problem is that this can actually progress to something more serious if we're not holding the charge at the AV node for that long at all. Left ventricular hypertrophy, this is sometimes a little bit tricky because what you've got is increased R wave peak time. Look at these R waves. I mean, these are just very tall. They're very tall, right? They're running into each other actually. And the problem here is sometimes people might think, if you look at that might look like an ST or a T wave abnormality in the lateral leads here. But actually, this is just delayed repolarization. And it's because you've got thickened LV walls and the charge has to travel through a thicker piece of tissue. So it's leading to prolonged depolarization, leading to delayed repolarization in your lateral leads. So although this might look like a STEMI, it's not a STEMI. There is actually, if I remember the name of, there's some sort of a theory that goes along with this that tells you that, your ST elevation has to be more than a third of the normal. So in this case it's not more than a third, it's just that these R waves are running into each other. I'll put it up on the screen for those of you who are interested, but left ventricular hypertrophy is a little bit more complicated to get your head around. It can be confused easily with a STEMI, but just remember that when you're looking at an ECG, you're thinking of all your differentials, and LVH should be up there when you're thinking about a STEMI as well. And that's the end of part 3, the final part. So if you've got any questions for me, do send them through to hsreviews05@gmail.com, or you can leave them down in the comments as well. But I hope that this has been useful. Alright everyone, well that is going to be the end of this video and the end of the ECG series. Now depending on how much love you have given this series, I may make more videos on ECGs, because really this was only touching the surface, and although you've probably got a good understanding of the basics now and some common rhythms, there is a lot more to the ECG world. But I hope that I've equipped you with some of these basic skills so that you can go out and really read any rhythm you want. But of course I'm more than happy to keep making more videos, so do let me know down below if this series has been useful for you. And as always, if you have any questions, do email me, DM me, or put it down in the comments and I'll get back to you. Thank you so much for watching. Goodbye.